Hi all. Today's our topic is CTG interpretation. This section will be the continuation of my last video. My last video was basic information about CTG. So those who have not watched the basic information of CTG, please watch that video first. Then it will be very easy to understand the CTG interpretation. So without wasting time, we can move on to our today's topic, CTG interpretation. First, we'll see how to read a CTG. To interpret a CTG, you need a structured method to assessing its various characteristics. The most popular structure can be remembered using the acronym DR C BRAVADO. DR means define the risk, C for contraction, BRA means baseline rate, V for variability, A for acceleration, D for deceleration, and last O for overall impression. With these characteristics, we can read CTG very easily. Here we can see the first characteristics, that is define the risk. In that you need to assess the current pregnancy is whether in a high or low risk. This is important as it gives more context to the CTG reading. For example, if the pregnancy is high risk, your threshold for intervening may be lowered. In this slide, we can see in which all are the reasons a pregnancy may be considered high risk. The first one is maternal medical illness, gestational diabetes, hypertension, asthma, obstetric complications, multiple gestation, post-date gestation, previous cesarean section, intrauterine growth retardation, premature rupture of membrane, congenital malformation, oxytocin induction or augmentation of labor. Apart from that, we have few more risk factors such as absence of prenatal care, smoking, and drug abuse. These all are the risk factors which we can expect during pregnancy. Next, we'll see the contraction. Record the number of contractions present in a 10-minute period. That means 3 contractions in 10 minutes. Each big square is equal to 1 minute. So look at how many contractions occurs within 10 squares. Individual contractions are seen as peak on the part of CTG while monitoring uterine activity. While assessing the contraction, it is very important to find out the duration and intensity. The duration means how long do the contraction last. Intensity means how strong are the contraction, which can be assessed by palpation. In this strip, we can see the frequency of uterine contraction, which will be 3 to 5 times in every 10 minutes period. Each contraction lasts 40 to 60 seconds. In the down, there will be reading for the uterine contraction 20, 40, 60 like that. It will be measuring in mmHg. So here the mother is getting uterine contraction up to 40 mmHg. That means the mother is getting mild to moderate uterine contraction. So in this strip, mother is getting around 4 uterine contraction. Next, we'll see the baseline rate of the fetal heart rate. The baseline rate is the average heart rate of the fetus within a 10-minute window. Look at the CTG and assess what the average heart rate has been over the last 10 minutes. Ignore any accelerations or decelerations. A normal fetal heart rate is between 110 to 150 beats per minute. In this CTG, we can identify the baseline heart rate will be 140 beats per minute. Here we'll see the fetal tachycardia and bradycardia and its causes. So as you know, the fetal tachycardia is defined as the baseline heart rate greater than 160 beats per minute, whereas in case of fetal bradycardia, it is defined as a baseline heart rate less than 120 beats per minute. So first we'll see the causes of fetal tachycardia. These are fetal hypoxia, chorioamnionitis, hyperthyroidism, fetal or maternal anemia, fetal tachyarrhythmias. Mild bradycardia of between 100 to 120 beats per minute is common in the following situation. These are postage gestation, occipito-posterior or transverse presentation. Severe prolonged bradycardia less than 80 beats per minute for more than 3 minutes indicates severe hypoxia. Next, we will discuss about the variability. It refers to the variation of fetal heart rate from one beat to the next. Variability occurs as a result of the interaction between the nervous system, chemoreceptors, baroreceptors, and cardiac responsiveness. Therefore, it is a good indicator of how healthy the fetus is at that particular moment in time. Normal variability is between 10 to 25 beats per minute. To calculate variability, you look at how much the peak and trough of the heart rate deviate from the baseline rate. In this strip, we can identify the average variability will be around 20. So, in case of variability, it can be categorized into 3. The first one is reassuring, that means more than or equal to 5 beats per minute. In case of non-reassuring, it will be less than 5 beats for between 40 to 90 minutes. In case of abnormal variability, it should be less than 5 beats per minute for more than 90 minutes. Next characteristics is acceleration. They are an abrupt increase in baseline heart rate of more than 15 beats per minute for more than 15 seconds. The presence of acceleration is reassuring. Antenatally, there should be at least 2 accelerations in every 15 minutes. Accelerations occurs alongside uterine contraction is a significant of a healthy fetus. However, the absence of acceleration in a normal CTG will be considered as abnormal. Deceleration are an abrupt decrease in baseline heart rate of more than 15 beats per minute for more than 15 seconds. Next, we'll see variable deceleration. It will be observed as a rapid fall in baseline rate and a variable recovery phase. They are variable in their duration and may not have any relationship to uterine contraction. Most of these conditions will be seen in case of amniotic fluid volume reduction. Variable decelerations are also caused by umbilical cord compression. Variable deceleration can sometimes resolve if the mother change position. The presence of persistent variable deceleration indicate the need of close monitoring. Variable deceleration without the shoulders is more worrying as it suggests the fetus is in hypoxic state. Next, we'll see what you mean by late deceleration. Late deceleration begins at the peak of uterine contraction and recover after the contraction ends. This type of deceleration indicates there is insufficient blood flow through the uterus and placenta. As a result of blood flow to the fetus is significantly reduced, causing fetal hypoxia and acidosis. In case of reduced uteroplacental blood flow can be caused by maternal hypotension, preeclampsia and uterine hyperstimulation. The presence of late deceleration is taken seriously and the fetal blood sampling for pH is indicated. If fetal blood pH is acidic in nature, it indicates significant fetal hypoxia and it need for emergency C-section. Here we'll see about prolonged deceleration. A deceleration that lasts more than 2 minutes is called prolonged deceleration. If it lasts between 2 to 3 minutes, it is classed as non-reassuring. If it lasts longer than 3 minutes, it is immediately classed as abnormal. So the immediate action should be taken. That means we need a fetal blood sampling and emergency C-section should be performed. Next type of CTG pattern is sinusoidal pattern. This type of pattern is very rare. However, if present, it is very serious. It is associated with high rates of fetal morbidity and mortality. It is described as a smooth, regular, wave-like pattern. Frequency of around 2 to 5 cycles in a minute. Stable baseline rate around 120 to 160 beats per minute. No beat-to-beat variability will be present. A sinusoidal pattern indicates in case of severe fetal hypoxia, severe fetal anemia, fetal or maternal hemorrhage. Immediate C-section is indicated for this kind of pattern. Here we can wind up our today's section. This is about the detailed interpretation of CTG information. So in the next class, we will meet with another episode of midwifery topic. Till that, take care. Bye-bye.